some of you probably know me, and for those who don't know me, my name is Jan Brožík. I'm radiologist at UHL. I do radiology rounds where I learn a lot from intensivists, and it's really interesting to go through the cases and get more clinical history, and sometimes we change the outcome of scans and or imaging, and we get to the bottom of the things. I would like to make this session interactive, and I think in the seminar room in Glenfield Hospital, it's quite bright. So I would suggest if you can probably do something about the blinds. There's too much of light. Yeah, and hopefully the quality of images will be sufficient. So we can kick off, and please do not hesitate to interrupt me. Yeah? This should be interactive, and those who want to say or comment on the films, please do so without asking for permission. So here's the first case. Gentleman with an empyema, 62, and there's a simple question: where is the NG tube? So who can tell me where is the NG tube, and are you happy with the position? No. You are not happy. That's very good. We are not happy. I'll show you the inverted image. It's exactly the same image, but I prefer to look on both normal image like this and inverted image, because I feel I get a bit more of information. So who can tell me where is the tip of the NG tube? Anatomically. And don't be shy. All right. So the NG tube goes like this, then it bounced back and ended here. So where is it?
Left or alone?
Absolutely. This is a bit unusual. We are used to see the NG tubes going into the right lower lobe. For some reason, the NG tube did this. So it was spotted, it wasn't missed, and we did a follow-up X-ray that showed the correct position of the NG tubes. So everyone was happy. You might think I am a bit monotonous, but I think this is very important. We have a 78-year-old male who was admitted with ruptured AAA and underwent surgery. And this X-ray actually led to several emails, including complaint that we missed displaced NG tube. I'll show you the inverted image. I think we can see the NG tube better. Obviously, this is a postoperative film of a patient on ITU, so it's quite busy and it's easy to miss things. So where's the NG tube? Who wants to tell me? And just to show you where are the relevant anatomic structures. So the carina and the left main bronchus, they are here. So yeah, we have ET tube, central lines on both sides, and there's an NG tube that goes to the left and then coils like this. Where is the NG tube? That is a question. Or Or you don't have to tell me where is the NG tube. I want you to tell me, can you use it or you shouldn't be using it? That is the question.
Shouldn't be using it.
So you are happy to use it?
No, it shouldn't.
No.
Okay, and why you don't want to use it?
That's the right place. This
Doesn't go through the midline, it's not below the diaphragm.
Okay, so it took us some time, and I'll show you this. So it's the same X-ray. I took some measurement, and this is 35 millimeters distance between. So that loop measures 35 millimeters. So do you think it is in the left lower lobe, like in the previous case?
Too big for the left.
could be in the distal esophagus.
Well done. This gentleman has got hiatus hernia. Yeah. So it was in the right place. And uh, actually you can see the left main bronchus, and it almost looks like it went into the airways, but in the periphery you shouldn't in the peripheral airways you shouldn't have such a big space. Yeah. And he had also enlarged left atrium that pushed esophagus to the side. So we got this a strange picture. So it was a good position, but looked like a wrong position. And my advice is do not follow the guidelines blindly. We have that mantra where the NG tube needs to go, but I can show you many cases where the individual anatomy doesn't follow the guidelines. So this is something that is important to bear in mind. And the solution to this is compare with previous imaging. And I accept that you might not be confident in assessment of CTs. So speak with us. Yeah. As I said, I'm a bit monotonous today. So again, we've got a lady who is 48. She is on ECMO. She has ARDS. That was from COVID era. So my question to you is, where is the NG tube? And I'll show you both. So are you happy with the NG tube position? There's nothing tricky. Just be brave. Say yes or no.
No.
So it is in the wrong position, you think?
There's not enough information.
Well, welcome to the world of radiology. We never. Yeah, we have to deal with what we've got. So she's on ECMO, and they put an NG tube, and just wanted to know if it was in a good position. So yeah, it is basically in the midline. It definitely goes below the carina. I know it's a bit bowing, but it's not that bad, and it's below the diaphragm. So this is textbook position. I'm happy with the NG tube. I'm happy with the ECMO cannula. But we'll move on. There was another X-ray, so done later. Are you, and the lungs got better? Yeah, so the patient responded to the treatment, which is fantastic. Are you happy with the position of the NG tube in this case?
We can't see the tip.
Well, don't worry about the tip. It's in the stomach. I can reassure you. So we are happy. Yeah. Is there is there anything else you are not happy with?
The position of ECMO cannula.
Exactly. So we'll go back, and this is how it should be. Yeah, the tip should be in the IVC somewhere at the level of or ideally below the level of hepatic veins, yeah, and the position changed, but this wasn't originally commented on, and the patient wasn't doing very well, so we did CT scan, and this is the cannula, and I'll show you a couple of reconstructions, and this is really worrying. Yeah, so when they washed or moved with the patient, they dislocated, they pulled it back, the cannula, so they quickly pushed it in, and they actually perforated the right atrium, but it's important to compare the X-rays. That's why I'm showing you this this case. There has been massive change in the position of the ECMO cannula. So this is what happened. I think some of the consultants remember this case, and there are some reconstructions, and CT shows that. But the message here is you can actually make that diagnosis, or at least suspicion, from the chest X-ray. And I'm not promoting any websites, but the rule in radiology is go and compare, yeah, with previous imaging, and it's so important. And in intensive care, it is not just about comparing with the most recent, but at least 3. But sometimes I end up comparing even with preoperative films, because I can find an answer to our questions. And obviously, you should know the right and wrong positions of cannulas. I have to say, when I came to Glenville Hospital 12 years ago, and when I saw for the first time the ECMO cannula, I wasn't sure what I was looking at. And in some specialized ITU units, they use things that they don't use anywhere else. So it's in particular radiologists who can be quite puzzled and can make a mistake because they don't recognize a line or tube. Right, I promise this is the last time I'm asking you where is the NG tube. So, and this is not from ITU, that was someone who was operated in ENT. So who can see the ET tube? Is there ET tube, or there isn't? So can you see it, or you can't?
I can't see it.
No.
Yes, and that's I would say, a correct answer, because the clinical team actually reached out and asked radiology registrar, where is the cannula, and they say, I don't know. So, but the cannula, not the cannula, the NG tube, it is there, and this is also important message for you guys. If you are assessing chest X-rays, you need to have a proper big screen with good resolution. And that's why when I come to the ITU, I switch the lights off. And I prefer to close all the curtains to make the room dark, because otherwise you might be missing important things. The NG tube is actually here. Yeah, you can see it in the upper mediastinum, but it basically disappears here, and we can see the tip in the stomach. Yeah. However, this is a bit tricky, and we had that problem before. And yeah, you don't want to feed someone into their lung, so you want to be 100% sure. When I magnified this, and if I change the brightness of the screen, I was able to see it. But the problem is we are trying to not use these tubes at UHL, but now and then it happens that there's not enough of contrast material in the tube, and we struggle to see it. And in radiology, everyone is excited that you try to improvise by injecting contrast, but I think it's a smart way if you inject small amount of if in case like this, yeah, we shouldn't be using um, uh, uh, those NG tubes, but it it does happen. So one solution is to speak with radiology. Our screens are better and our eyes are trained, so we should be able to spot it. But in this particular case, it was actually missed by radiology registrar. So this could be challenging, and I think we need to feed this back to manufacturers. And I think I'm not sure if Martin Murphy is around, but he spent quite a lot of time with this issue. So, but it can happen if you're on call that you get NG tube that you can't see. Right. Any comments or questions to this case? No. So we'll move on. So we've got a lady who's 74. She had cabbage, and after surgery, she was doing well, but then she developed severe hemoptysis. And question is, can we explain what happened to her so we can do the right management? So if you have someone with severe hemoptysis, you want to do the CT, but taking an ITU patient to the CT, sometimes it could be almost like military drills. You have to take quite a big team, and during the pandemic we had to ask the security to block corridors and stuff like that, so it's not ideal. And we have this fantastic imaging modality called chest x-ray that can answer our questions. So this is the x-ray that was done immediately after the surgery, so everything looked basically okay. This is expected finding um, uh, 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 of a patient after cardiac surgery. Then there was another X-ray, and is there anything that you don't like about this X-ray, or are you happy with everything with this particular X-ray?
The pulmonary artery catheter.
Yeah. Yes, it is. It is there. Are you happy with its position or not?
Uh, I think it looks like it's okay. The position is okay.
Absolutely, and I agree with you. There is, if I go back, uh, if you look at this area, so that was that original film, and this is a subsequent film. We have new consolidation here, yeah. And if you have someone with hemoptysis who develops new consolidation, it still could be infection, but it's probably that area where the patient bleeds. And this is about satisfaction of search. What we well, we did it in the radiology round, and that helped us to find what the problem was. There was also this X-ray. So, are you happy with the position of the PA catheter?
I think it's too much deep in.
Absolutely, I completely agree with you. So, what is the commonest complication of a PA catheter insertion?
I mean, a pulmonary artery rupture.
Well, you have to push
Arrhythmia.
quite hard.
I mean, arrhythmias.
Well, it will be pulmonary infarction. I hope you don't see that many, but yeah, you're basically occluding a vessel, so you can have pulmonary infarction. But it wasn't the case. But based on this position, CT was recommended, and CT scan showed us this. This is a reconstruction. So this is a pseudo aneurysm of the pulmonary artery. Here's another reconstruction that shows nicely that pseudoaneurysm, and that's why we had that blood in the lung. My colleagues, interventional radiologists, they embolized it and the hemoptysis stopped. Yeah, we still have this consolidation, but the message here is you have to review a series of X-rays, and in particular, if something changes with the patient, it's very good practice to check really several X-rays, and it could be complicated because some of your patients might have 10, 15, and some of them even 20 X-rays, and we were happy with the position of the catheter on this film, but then here is the basically smoking gun. This is what caused hemoptysis. So, and actually, again, you can see it on X-ray, but go and compare and review at least 3 most recent X-rays, but sometimes it pays off to dig a bit deeper, and you can find the cause for the symptoms. Any questions to this case? If not, we'll move on. So this is a lady who had Ivor Lewis procedure for achalasia. She was 47 at the time of the procedure. So it's quite extensive procedure, but this is not cancer. Yeah, and she's fairly young. So she had the procedure and she wasn't doing very well after the procedure. And in her case, the most important thing was a review of the preoperative chest X-ray. It looked completely normal. I think many of the consultants are familiar with this case, or perhaps all the consultants. This is case from 2014. What's wrong with the X-rays after the surgery? The X-rays below, and I can show you them in detail. But again, focus on the right lung, yeah, and you can see on the preoperative film, the lung was completely normal. There was nothing to comment on. It was completely clear. So here's the one of the first and probably the very first X-ray after the surgery. What's wrong with the right lung? Don't be shy. So
Subcutaneous emphysema.
I'm not sure if I can see subcutaneous emphysema, but you know, in a patient who had thoracotomy, who has at least 2 chest drains, you know, unless it is extensive, it's even expected. But my question is about this opacity. It wasn't there before surgery, and it appeared. Say that again.
Right upper lobe collapse. It looks like a pneumothorax.
Yeah.
Possibly.
Yes, so my screen probably has better resolution. I can't see a pneumothorax, but there's this strange opacity, and it doesn't look like completely consolidation. Yeah, you can. That's a very good thought. It could be the right upper lobe collapse, but you would expect some volume loss, and there is not much of volume loss, and this is quite tricky. Plus, we have this line here, so. And that line wasn't there on the preoperative film. So any idea?
Is that a retained foreign body after the surgery?
That's a good thought, and the surgeons were in, and they shouldn't, but unfortunately it can happen, but it's not a foreign body. I'll move on. So a couple of days later, yeah, there is actually surgical emphysema on this one. I agree. And it changed. So we've got this extensive opacity. The patient had 2 drains, 2 pleural drains in. There's well, there's probably this tiny pneumothorax, but we still have that line going towards the hilum. So now it really doesn't look like collapse. So what do you think? What's going on? Any ideas? Okay, no one had any ideas. So we did CT. Yeah, so again, I would like to stress there was nothing before the surgery, then something strange appeared in the upper zone, and there was that line. Again, we can see that line on the subsequent X-ray going to the hilum. So we did a CT, and this is not focused on CTs, but nowadays without CT, it's very difficult to assess X-rays. And well, if you have CT available, you should be looking at it if you are interpreting X-ray. So what do you think about this line? Yeah, that's the line we saw on X-ray. And we've got plenty of ground glass, some septal lines. Yeah, any ideas? It doesn't look like normal lung. What's going on? Well, that's what the radiologists who reported it said. They didn't know. There is a CT, well, another reconstruction. So what do you think about the fissures in the lung? This is front, this is back. So we've got one fissure here, another here, and we can see the same thing here. And actually we can see occlusion of the bronchus, but there was also occlusion of the pulmonary artery, right pulmonary artery. This is puzzling, isn't it? So what's going on?
Infarct.
That's a very good thought, but why there should be an infarct in a patient who was previously fit and well and only had achalasia, and they did Ivor Lewis. You can see here the gastric pull through. Yeah, so
Ivor they've tied it off by accident,
Yeah.
maybe.
yeah, but is it?
The chest drain.
Yeah, no worries. I'll show you a second CT. So this is a contrast scan. And what do you think about that consolidation? What's going on?
It's all infarcting.
Absolutely. But can the whole lung infarct? You said if they close the pulmonary artery, but I think it would be quite unusual, and the upper GI surgeons, I think they don't try to occlude the main pulmonary artery. What happened?
With the chest drain.
Yes. So yeah, the chest drain went.
Sitting.
Yeah.
Is it the chest drain sitting in the pulmonary artery?
No.
Oh.
Pull up the bottom.
And you have also occlusion of the bronchus, and it is not an abrupt end. You can see the tapering. Yeah. So you can see a beak, and I showed you the fissures. So is it normal position of the lung fissures on the right side? So is it normal to have right middle lobe at the back?
Oh.
What happened?
Oh.
Yeah, can you hear me?
Yes.
Is it twisted?
Yes.
Yeah. No,
Well
I was
done.
gonna give a clue. Can you hear me? Yeah.
Yes.
Twisted.
Yeah, I'm familiar with this case, and it's one of the one of my early cases that I got involved with ECMO. She went on to ECMO. If I said that during one lung ventilation, this could have been avoided if the lung was reinflated under direct vision manually, then this would have been picked up.
Yeah.
It got twisted.
Yeah, but one, I don't know who that was, but someone said if it got twisted, and I completely agree. Unfortunately, at the time, so there was some delay in the reporting of the chest X-ray, and this is chest X-ray teaching. And what I would like to stress, it was obvious from the very beginning, but because this is such a rare thing, no one really thinks about it. But you know, if you see something strange, you should think about it. If you remember Will Smith in Men in Black, when they were hiring him and he went to the shooting range, they showed him uh, nasty aliens, and he was the only one to not shoot. And then he shoot a picture of a 10-year-old girl who was smiling, and they asked him why you do that. Uh, his reply was, well, this is really suspicious. You have all those nasty beasts, and then 10-year-old girl who's just smiling. Yeah. So, and obviously this is a sad case, and the patient came to a harm. But if you see something that is where it shouldn't be, yeah, think twice. Why is that? So the fissure going to the upper lobe, and then on CTs, if you have fissures where there shouldn't be, and on sagittal reconstruction, when you get middle lobe posteriorly, there's something very wrong. Plus, you can see this tapering, the beak-like pulmonary artery and occlusion of the bronchus. So even on imaging alone, we could have picked it up earlier. So this is, hopefully we won't see that many cases, and this is already in lung that is infarcted, that is dead, and was taken out subsequently. So this is when she was on ECMO. Yeah, but it's important to learn from this case. I presented it in to the radiology registrars and consultants at UHL, because this shouldn't happen. It shouldn't be missed on imaging. And we actually published the case for those who would like to see it. It can happen. Typically, after lobectomies, you can have a torsion of a lobe, but the whole lung, it doesn't happen very often. So, yeah.
I just wanted to reiterate, Jan, I know it's a radiology teaching, but anesthetically in theatre, if a patient's under one lung ventilation, the lung should be reinflated under direct vision. And if it doesn't reinflate, then this potential complication will be picked up in theatre.
Yeah. And thank you for that. Okay, I'll move to another case. So we've got a young man who was, sorry for wrong spelling, a recreational cannabis user. He developed life-threatening asthma and was referred to us for ECMO. So here is, oh, sorry, I'm going the wrong direction. Okay, here is his X-ray. So we can see chest drains on both sides. We see ET tube, NG tube, a central line. We see ECMO cannula, and we see those bilateral upper lobe consolidation. Yeah, so it's very, we can't be very specific without CT, and even with CT we can't really tell you what kind of infection that is and stuff like that. But it was reported as bilateral consolidation. It was a bit puzzling because you in patients who are unconscious, you usually have consolidation either everywhere or with lower lobar predominance, and this upper lobar predominance was a bit unusual. So here's the inverted image. Does anyone know what we are looking at? I have to say I didn't know. Even on CT, I struggled. Any ideas? Don't worry, I'll move on. We did a CT, so a small pneumothorax, and the drains were already in. We've got a drain in the fissure on the other side, but we know that from chest X-rays. But we have these extensive ground glass opacities. This one looks like a almost a track. It goes from the front to the back. Yeah, and on the other side it's similar. And if you look on sagittal reconstructions, you have this central um, uh, hyperdensity surrounded by extensive ground glass opacities, and the same thing you've got here. Do you know what happened to this man? And he ended up on ECMO, and his lungs look normal, as opposed to that patient we reviewed earlier. He does have a little bit of bronchial wall thickening, so that's something we see in asthma. This is bronchitis. So does anyone want to comment? Is this pneumonia or is this something else?
Could it be infarction?
Could be, but everything that is brought to the lungs by a bloodstream, it usually ends in the lung bases. So it would be quite unusual to have biapical pulmonary infarcts. Any other suggestions?
Inhalation of toxic gases.
I missed that.
ILD?
ILD, again, interesting idea, but usually ILD, with some exceptions, affect lower lobes, and he's a young chap, so well, you can have ILD in young people, but yeah, it makes it less likely. So any other ideas? And look at this. We've got this density and plenty of ground glass. And he developed bilateral pneumothoraces, which is a bit strange. So when we do lung biopsy, and he didn't have a history of lung biopsy, we see sometimes this. Yeah, so lungs are full of blood. So if you hit them with a needle, you can cause pneumothorax plus hemorrhage. So this is an appearance of pulmonary hemorrhage, and it looks like trauma. Do you know what happened?
The needle decompression.
Yes, and I have to say, I've seen recently another case, and it's easy for a radiologist to make judgments and comments from a cozy reporting room, but I'm a bit surprised by the extent. I'm not sure what is the caliber of the needles, but this is iatrogenic injury, bilateral pneumothoraces, and quite extensive lung hemorrhage caused by insertion of the needles. He had asthma, or life-threatening asthma, so they probably tried to do everything they could, but in addition they damaged his lungs. And I'm not sure what is exactly the guideline, but one should be very careful with this, because the patients are coming to harm from my point of view. But he quickly recovered on the ECMO, and he went back home. It's the same thing with the lung torsion. If you are looking at on CTs, look on 3 planes, not just one, because axial planes can be misleading. So we've got another patient after cardiac surgery. I think he was doing well, but he had a chest X-ray, and who and this is mainly for trainees. So is there a trainee who would like to tell me what is the pathology on this X-ray, and I can show you even inverted image. So right side, can you see a pathology, and what would you do with it?
I'll do the thorax.
Okay, a pneumothorax. So would you drain it?
I mean, if the patient is comfortable, like no respiratory distress and all, we can monitor the patient.
Sure. I can't magnify that X-ray, but there is a rule. If you have pulmonary vascular markings going beyond that line, it's not a pneumothorax. Yeah. And again, it depends on the resolution of the screen you are using. But we have some vessels that go beyond, and this is actually not very sharp line. It's a bit softer, and but it looks like it is within the lung, and we have another line here, yeah, and we have another line here, and that line on the left side actually goes into the mediastinum, and so when we invert it, we see exactly the same thing. It was drained, and we again have some lines, but again, this is iatrogenic injury to the lung. And I'll show you what it causes. And I've seen this before, because on smaller screens, it does look like that. But in particular, in elderly and who are in supine position, you can have many skin folds like this. Yeah, so that's his CT. And those skin folds, unfortunately, given the anatomy, they can mimic, they go along the chest wall, and they really mimic pneumothoraces. So before you put a drain in, and if you see something like this, and a patient in their 70s, 80s, usually not very obese patients, and if you see something like that, think twice before you put the drain in, because you might be draining a skin fold. So that's after he was drained. So that's that pneumothorax, but he didn't have pneumothorax at the time of the drain insertion, or before the drain insertion. And those are the skin folds that can trick you into thinking there is a pneumothorax. This is another example, not an ITU patient, but we see those patients who are coming for LVRS procedure, very bad emphysema, and we almost can't see any vascular markings, yeah, but this is emphysema. And what is interesting with these patients, they usually have history of several ED attendances where they drained their pneumothoraces, and drains didn't help. Yeah, that's typical for those patients. So this is where we can be tricked into thinking, oh, this is probably a pneumothorax. So this is an example. He actually developed a pneumothorax. So here is the real pneumothorax with a chest drain, yeah, in with some fluid. And if you really look at it, a pneumothorax has always that sharp line. This is the visceral pleura. This is the appearance of visceral pleura on X-rays, and shouldn't be mistaken with a skin fold. Yeah. So this is an example. Here it doesn't have a pneumothorax. This is just a massive bulla, basically empty space, but it doesn't have a pneumothorax. And here's just his CT to show you what was there. So these are really badly damaged lungs that may mimic a pneumothorax. Do you have any questions? No, that's or comments perhaps. I'll move on, and it's just a brief conclusion. What I wanted to show you with these cases, that a careful analysis of the film is necessary, and we can easily make a mistake. They did a study of 1,000 ITU films, and up to 35% of films had clinically unsuspected abnormalities. When reading portable films, there are many challenges. Obviously, there is that known magnification of the mediastinum. Many patients are rotated. It's the beam angulation, so we call it AP, semi-erect, erect, supine, but we hardly ever have a beam that is going perpendicularly to the body. Usually there is some angulation, so sometimes you see a pacemaker electrode that looks like it is in the stomach, but it's not in the stomach, it's in the heart, but it projects over the stomachs. Some films are not very good quality. There could be underexposure. There are all sorts of artifacts. One of the biggest problems is that on the patient and behind the patient, there are too many lines and cables. And it happened several times that NG tube in the right lung was missed because of the amount of lines or cables on the patient. It was just satisfaction of search. The person who looked at it said, "Oh, this is quite busy. I think sorry, everything is fine," and they missed the dislocated NG tube. It's good to have some kind of review system. Yeah, so know your lines, tubes, pacing leads, devices. This is more applying to radiologists because not many radiologists will go upstairs and see the patient. So you might get reports claiming that there is some strange line, and in fact, it will be a line on the patient, not in their body. Uh, it's important to check the lungs, the pleura, mediastinum, but also upper abdomen, yeah, because it's visualized and you can find pneumoperitoneum, you can see ileus or bowel obstruction. Sometimes you can even see signs of bowel necrosis, but it's not very common. There's that 3-film rule. So compare with at least 2 recent films, but sometimes it pays off to review even pre-operative or film or imaging before the admission. And I recommend to everyone, go and see how films on ITU are done. You probably have that experience in radiology. Not every radiologist knows how it is done. We can complain about the quality, and in fact, that's the best achievable projection. Correlation of findings with CT scans, it's useful. You can find explanation why that NG tube is not going in the midline, for example. Uh, uh, in radiology, we frequently don't have the full clinical history, so you might see reports saying things that don't make much of sense, but the person who reported the film probably didn't have much of the history. What I think is important, and I'm trying to do that, and I'm teaching our registrars, we need to communicate with clinical teams, and we need to communicate with you guys, because you will tell us what the problem is and what you need to know. We do the radiology rounds, and I find them useful, and I hope they are useful for the for your patients and for you guys as well. Obviously, knowledge of lines, tubes, devices, procedures, it's important. The portable X-rays are always limited. It's not a great quality, and we say they're used to identify gross abnormalities. But if you really think about it, this could be the only imaging, a part of the ultrasound you do yourselves, the only imaging that the critically ill patient can have. So I think it's important to be able to read films correctly. I have some recommendations if you want some literature. So this is a very good book, and it's not very long reading, but they're all important things, including the intensive care patients. And I have also link for that book, and there's a radiology assistant, which is a Dutch website that is very good on cardiovascular device. So something that can help you. If you can attend IT rounds, that's absolutely fine. We can discuss interesting cases and perhaps sometimes find answers to your questions. And here's that case of lung torsion that we published some time ago. Do you have any questions or comments? If not, I think I'll close this. I spoke with Rajni before we started, and we might do. Oh, Rajni wants to say something.
Thank you, Jan. Thank you for the discussions. I think, yes, we all remember that torsion patient, as you said, because again, as Rakesh said, it's really important from an anesthetic point of view to ensure that the lungs are re-expanded at the end of one lung ventilation. And if that had been done, perhaps she might not have had it, but you never know. It's all said in retrospect, isn't it? But I was just wondering whether we could have one more session with just sort of describing basics of CT chest, in terms of CT chest anatomy.
Absolutely.
Because I think that'd be really useful for the trainees as well, because we, as you said, throughout, we do so much CT chest. We just don't leave it with chest X-rays. It would be really useful for us to understand anatomy.
So with focus on anatomy.
I think so. I think it would be really useful, and some pathology thrown into it as well.
Yeah, so I'll liaise with Zoe and we'll do it at some point this year.
That would be great, Jan. Thank you.
Yeah, thanks, Anne.
Okay.
Thanks, Anne, and thanks, Zoe, for coordinating it all.
That's all right. Thanks, Jan. That
you.
was really interesting when I could dip in and out of the units a bit bonkers, but yeah, it looked good. So thank you.
All right. Thank you very much. Take care. Bye-bye.
Thanks.
Cheers.
For those of you who haven't met, I'm Nick. I'm one of the anaesthetic registrars in Glenfield, so I've been asked to present today. And the article that I'm going to be talking about is about a novel treatment of severe community-acquired pneumonia in ICU. So it was a trial that was conducted, data collection between 2017 and 2020, and it was published in the Journal of Critical Care in February this year. And there's a link which I can send out to the paper itself afterwards if people are interested to read it. So why this paper? So obviously we see an awful lot of pneumonia cases in ICU, and the NICE guidance from 2012 suggested that we get anywhere from 500 to 1100 cases per 100,000 per population per year in the UK. About 20% of these need hospital admission, and up to 10% of those need ICU care. So we are talking large numbers overall. And in these patients that get admitted to ICU with community-acquired pneumonia, there's up to a 30% mortality. So the idea of this paper is to try and find something else that we can do to try and reduce the mortality in bacterial pneumonia. So the paper is looking at the premise that mesenchymal stem cells, which can be harvested from donor patients, have immunomodulatory effects and antibacterial properties. They've used them previously in studies looking at ARDS, and this is the quote from the paper. So the expanded allogeneic adipose-derived mesenchymal stem cells, which is a bit of a mouthful, might address the underlying immune dysregulation in sepsis secondary to community-acquired pneumonia. So it's meant as an adjunctive therapy rather than a sort of a curative treatment, so to use in combination with our existing treatments. This is a picture showing how they harvest some of the stem cells. They take great big lumps of fat, spin them down, separate out the stem cells, and then they can culture them from there and refine it into something that's a little bit more user-friendly. So the study that was actually performed was called the SEPCELL trial. It's a phase 1b/2a study, so it's mostly looking at the safety aspect of things rather than sort of end effectiveness. And the substance that they were using is called CX611, which is these stem cells made into an IV formulation, and they were testing it on patients who were admitted with severe bacterial pneumonia. So they took data from 20 hospitals in various countries across Europe. So it's France, Belgium, Spain, and Lithuania. And the recruitment was between 2017 and 2020. And as I mentioned, the primary objective was to make sure it was safe, first of all. Secondary objectives they're looking at was to see if there was any sort of noticeable beneficial effects from this as an adjunct. So the way they selected the patients was people admitted to ICU with a community-acquired bacterial pneumonia, and within 18 hours they were screened, and then either, if they matched the criteria, they were randomized to have either a placebo or the CX611, which was the test drug. They had 2 treatments, one on day 1, one on day 3, and this was blinded, so the people who were providing giving the treatment, the prescribers, investigators, people who were assessing the outcomes of the patients were all blinded to the intervention, and the infusions themselves were masked, so you couldn't really tell what was in them. They collected data up to about day 90, but then followed up until day 730, and the main cause for leaving the study early was if the patient died. So the inclusion criteria, they were looking at adult patients between 18 and 80, between 50 and 100 kilos, acute community-acquired bacterial pneumonia, so excluding the viral or other causes of pneumonia. And then they had to be managed in ICU and either require mechanical or ventilation or vasopressors within that first 18 hours of admission. So as I mentioned, they had a long list of exclusion criteria, so hospital-acquired or ventilator-associated pneumonias, aspiration pneumonia, TB, cystic fibrosis, etc., etc. If they were expected to die within 72 hours of admission, or if they had anything that would preclude them getting stem cell treatment, so malignancy, immunosuppression, previous other stem cell treatment, neutropenia, etc. So this is the diagram showing the enrollment. I don't know how well you can see it from there, but essentially they assessed 92 patients, so we're not talking big numbers. 84 of them randomized, 1 of them didn't meet the criteria, so it's a total of 83 patients that were analyzed in depth. 42 of them in the treatment arm, 41 in the placebo arm. This is a table of their baseline characteristics, so they were fairly well matched between the 2 groups, so broadly the same age, broadly sort of more female than male, but again matched for sort of age and gender. They were also matching them for disease severity, so they were looking at their Apache scores, Curb 65 scores and SOFA scores as part of the randomization process. So the idea being that in each treatment arm, whether it's placebo or investigative drug, you've got a reasonable match for disease severity as well as purely demographic data. They wanted ideally to have positive microbiological findings for each of the treatment arms, and again the numbers for matching those were quite good. So in terms of the outcomes, as I mentioned, the primary outcome was to make sure that it was safe and it wasn't causing adverse events. So the specific adverse events they were mostly looking for were thromboembolic events and also hypersensitivity reactions, because they're the things that have had associations with stem cell treatment in the past. So they monitored in general for adverse events through the patient stay and then sort of afterwards in their follow-ups. So treatment emergent adverse events, that's essentially any adverse event that occurs after the commencement of treatment. Specifically, they did lower limb Dopplers at day 5 or 6 to look for any thromboembolic disease, and then they did immunological testing as well to look for any sort of immune response to the stem cells that were given. They also looked at standard things that you check in ICU anyway, so vital signs, ECG, biochemical hematology measures, urinalysis, things like that, to see if there was any variation between the 2 groups. In terms of efficacy, the secondary outcomes, the things that they were looking for was whether the pneumonia was deemed to be cured, how many vent or vasopressor-free days, the 90-day survival and the 28-day mortality, either associated with pneumonia or all-cause mortality. So the results that they found, in terms of the safety aspect of things, they recorded lots of adverse events. And as I say, that could be anything that is considered an adverse event, such as anemia, AF, constipation, diarrhea, whether they're related to the treatment or not, but started after the treatment was initiated. And then serious adverse events, broadly similar numbers between the two. So things like multi-organ dysfunction or hypoxia, worsening respiratory function, anything that you could consider a serious complication. So this is the list of things that they considered adverse events. It's quite long. I've not gone into it in loads of detail, but the important things, sort of deep vein thrombosis and vascular issues, and then hypersensitivity reactions as well with the other ones that they were looking at. But it's fairly comprehensive. So hyperglycemia, very common on ICU, people who are receiving steroids and things especially. But that was analysed just for the sake of the study to see if there were any unintentional adverse effects. So they found that there was no particular difference in adverse events between the two arms, particularly between thromboembolic or hypersensitivity events. They had about 25 deaths in total during the study, similar numbers between the two arms, and there was no noticeable difference between the vital signs, lab measurements, ECGs. So that suggests that overall the treatment wasn't causing an increased number of adverse effects. Again, we're talking about small numbers, but it's a reasonable starting point to say that it's a safe drug to sort of investigate a little bit further. They weren't able to comment really on the efficacy of the drug because they weren't able to recruit enough patients, even though they were recruiting over 3.5 years. They only managed to get about half of the target number. They were looking for about 180 patients. They only managed to get 83. So they've not really been able to comment too much, apart from to say that between the groups, there was a similar time to cure, similar number of vent and vasopressor-free days, similar length of stay, but not really something that you can say is statistically significant. So in terms of the trial as a whole, the positive aspects of it, it was blinded, so all the participants, the caregivers, the doctors involved in the actual treatment of the patients were blinded. The randomization was good quality and well matched between the two groups. It was a multi-center trial, so it was looking at lots of different intensive care units, as I say, across 4 different countries, 20 intensive care units. So you should have a good spread of practice and a good spread of data from different patients. And they were very comprehensive in their data collection of adverse events. One of the serious adverse events that was listed was a hip fracture, which I don't think you could put down to having stem cell treatment, but they counted it anyway. Limitations from the study. So as I mentioned, they weren't able to get the numbers that they were looking at, so they had to close recruitment early because they just weren't getting enough. And 83 patients in 20 hospitals over 3.5 years is, you wonder why there were so few recruited. It's quite a labour intensive trial by the sound of things, so it might be that that was part of the reason for not being able to get the numbers they needed. Everybody who got the drug or the placebo, they got the same dose regardless of whether they were an 18-year-old 50-kilo patient or a 100-kilo 80-year-old. So they haven't really changed the dose depending on the weight. So they suggested that in future studies they would change the dose to sort of find out the maximum acceptable doses for different demographics, different ages and weight groups and things like that. And although it gives you a good spread of data, you can't say for sure. We all know how different ICUs can be between different hospitals, and when you're looking at 20 different units and you've got an average of about 4 patients per unit, you can't necessarily say that the rest of their care was all the same. So that's obviously going to have a big impact on the outcomes, is the overall care that they get while on ICU. They do sort of caveat that by saying that they should have similar standards of care, and they're all centres that were equipped to deal with big trials. So ideally, you should be able to get a good sort of relatively homogeneous standard of care, but there will be a lot of variation between them. So I think what you can say from this paper is that the treatment was well tolerated. You can't necessarily say whether it had any great effect on their survival or whether on their cure rates, but it gives room for sort of further investigation. gives it a sort of a reasonable safety profile, I guess, for future studies. So it needs more more investigation with some bigger numbers to get a proper idea of whether it's an effective treatment or not, because I can't imagine it's very cheap. They're doing more work about the specific biological and cellular effects and things like the antibody responses to the patients who have received it and things like that. So that's still ongoing. They are going to publish that separately. There's still more to be done, but it's sort of a reasonable start, I would say, for investigating something that's a bit different and could help reduce the mortality. Does anybody have any questions? All right, I will wrap it up there. Thank you.